Welcome to today's Women's ERG here at KLAS. We're doing a discussion on breast cancer awareness. We have Monique Rasband, a RD here at KLAS, and Jenn Munson, a CSM. We're so excited to hear their expertise. I'm going to turn the time over to them.
All right.
Thank you.
And
that's what we look like.
Yes, that's what we look like. One more. So I want to tell you a story. When I was a little girl, my grandma, we called her Mimi, had me help her with a very personal part of getting dressed. She had had breast cancer, and back in the 60s and 70s, they did something called a Halsted radical mastectomy. So they took the breast, all the tissue, all the muscle, so it went down to the bone. My grandma had a bra with a prosthesis in it. It was a foam, a foob. I call them foobs. I have foobs, so that's what we're going to call them. And I remember as a little girl seeing this terrible scar line across my grandma's chest and putting this prosthesis in her bra and helping her put her bra on. Because of the surgery, she couldn't raise her hand very well. Thankfully, and I want to make sure this is very clear, mastectomies are completely different. I've had a double mastectomy. I am very mobile. But as a little girl, seeing the ravages that my grandmother had experienced due to breast cancer was very sobering. Breast cancer runs in my family. And when I say it runs in my family, it runs rampant, just all over the place. If you look over here, this is a sampling of women in my family that have had breast cancer. And those with red circles were their lives were lost. Those of us with yellow circles have it or had it. And those with a green circle have the genetic mutation called BRCA1. That's the genetic mutation that runs in our family. When you are diagnosed with this, you have about a 90% chance of getting breast or ovarian type cancer. And the type of mutation we have in our family is a very aggressive type of breast and ovarian cancer. So how did we know about this? And this is where the discussion about prevention comes in and awareness. So growing up, I just always assumed when I died, I'd die of cancer because everybody else did, that I'd die of breast cancer or ovarian cancer. We didn't know why this was happening until my cousin, who's younger than me, was diagnosed with advanced breast cancer in her early 30s. She went as part of her treatment to Huntsman Cancer Center, and they did genetic profiling, and they said, hey, you've got this mutation, this BRCA1. There's BRCA1, BRCA2. They said, you have this mutation. This is why you've got this cancer, why you've got this aggressive type. You need to let your family know that this runs in the family. And so we did. Many of us got tested. Some people, including two of my family members, haven't been tested. I have feelings and thoughts about that. But I found out I was positive. And so I went in and I talked to my doctor. We did the genetic testing. Genetic testing is covered by most insurance. There's also programs if your insurance doesn't cover genetic testing. So we found out I was positive. We went in, had an ultrasound. Something looked wrong with my ovaries. I have very dense breasts, and so that complicated things with the mastectomy. But they're like, okay, we've got to definitely have a hysterectomy. And what do you want to do here? And I'm like, take them. I had to do a non-nipple sparing because even retaining your nipple with the mutation is too risky. So first thing I went through was a radical hysterectomy. Second thing I went through about 6 months later was a double prophylactic mastectomy, non-nipple sparing. And what we found was because of this testing and going in and being proactive, I had early stage ovarian cancer, where you're completely asymptomatic. And then on my left breast, we found out that there were precancerous cells in the breast and in the lymph nodes. So they called it like in situ cancer. So prevention saved my life. My aunt, who's the lower left-hand corner, that beautiful young woman, she had breast cancer, but it was ovarian cancer that took her life. And watching people that we love suffer from this disease and die from this disease is scary. But what gives us a measure of power is that there are things we can do as men and women, and men can get breast cancer too, to help protect ourselves. One of the things that you all should be doing once a month is doing a self-examination in the shower. And you can go online, you can see how to do that. If you're not sure, I'll totally tell you. I'm sure Monique would tell you. You want to go and check your breasts every month around the same time in the shower. Check for lumps, check for bumps, check for any changes in how your breast looks. The next really big thing is to make sure you understand, do you have dense breast? Do you have dense breast tissue? And I know that you're going to talk in more detail about that. Dense breast tissue, a lot of young women have this. It makes it more difficult to detect potential problems. So if you do have dense breast tissue, you want to talk with your doctor to see what else you can do for prevention. Third thing is get a mammogram. They're not bad. You get to wear a swanky hospital robe. There's a little bit of this and a little bit of this, and then you're done. And you have, especially when you're younger, that gives you a baseline to look at and compare all future mammograms. The last part of prevention I want to talk about, because it saved my life. Without this, I wouldn't be here. I really wouldn't be here. Is understanding your family history. Do you have a history of breast cancer? Do you have a grandmother, an aunt, a mother, a sister, a brother? Because again, men can get breast cancer. If you have first or second line family members, so an aunt would be like a second line, a sibling, or a parent would be a first line family member that has had breast cancer and or ovarian cancer, because the genetic mutations usually go hand in hand with ovarian and breast cancer. Talk to your doctor about genetic counseling and whether or not you need testing. Knowing this ahead of time, especially with mutations where breast cancer starts occurring in the 20s or 30s, is really important. And sometimes it's scary, the idea of getting tested and finding out you might have a mutation. I like to say, though, I am a mutant. That's no surprise. But yes, I am a mutant. Soy mutante. But knowing is power. Knowing lets you take control of your narrative. It also helps you be able to communicate to members of your family who might not know about this, that they too need to get tested. And so I wanted to close this with just looking at these beautiful women in our family. I look at all of those women in red lost their lives. All of the women in yellow are dealing with it. I will have to get scans for the rest of my life. And I'm totally cool with that. The alternative, not so cool with. But also, there are tools and procedures and testing that our foremothers and forefathers that died of this disease never had the benefits of. And I think it's so important that we take advantage of those. One thing that I've done is I've taken part in the IHC and also the Huntsman Cancer Genome Project, where I've shared, I'm like, take my DNA, spread my DNA, as weird as it may be. But we're doing that as well so that we can learn more about hereditary cancers, because there is a strong correlation between heredity and breast cancer. I appreciate my journey. I look at my scars, my foobs, proudly. I think of my grandmother and the scarring that she went through, and my mother and my aunties. And I'm really grateful to be a previvor, and we call it previvors and survivors, because I'm very grateful that I had that opportunity so that I can advocate and so that I can be here for my babies and my husbands and be here at KLAS. So any questions about what I've talked about today? All right. Anybody online with questions?
Thank you for teaching me foobs. I've never heard
Foobs. Well, yeah, it just, when they were like to you, people were very uncomfortable about, especially after the surgery, they were dancing around it. Because I came back, I went to the hospital like a double D cup, and I came back an A on a good day. And so there was like, before we did the reconstruction, so there was a lot of dancing about it. I'm like, no, it's nothing to be ashamed of. I'm getting foobs. I am proud of my foobs. And owning that and not being ashamed and being very, if you don't talk about it, there could be someone that doesn't know that missed out on a chance for education. So yes, technical term, very technical term. Okay, that's my story. Thank you.
So my disclaimer, I always laugh when they say she's the expert. I'm like, not clinically trained and definitely all taught by providers. And I think what's really interesting about that, and you mentioned it, talk to your doctor. We had on one of our podcasts an individual that ironically is a nurse, and so that is something definitely a step up from my background. And talking about how she received information from an older surgeon that at the time was probably great information, but fast forward in her care was dated. And I love how Jenn tied in what her grandmother went through and what is current, and even what will be in the next 1 to 5 years, who knows. So I wanted to share a little bit about my journey and definitely say I'm not an expert, but asking a lot of questions and hearing a lot of these stories. And I'm always fascinated, like how do these myths happen? And so I went to a website, American Cancer Society, and there is a great quiz. And over the years, I've collected, like we could literally have a whole day of quizzes and Mythbusters. And so I will not share all of those with you, but a couple of things that I find fascinating. And I shared a presentation with a women's group back in 2014, one in 2016, one in 2018. And just for fun, I pulled up those different quizzes. And even there were a few things that I was like, wow, that's not that long ago. And already some things were dated. Yeah. And maybe not, well, yes, dated, but up to date, just we didn't have that information. So I just share with you, leave this room with this education, but please continue, because there's likely something that we say here today and we'll look back on this and we'll go, wow, that was pretty crazy that we talked about that, or we didn't know that, or we thought that was the case. So real quick, you can either shout it out or quiet. So I'm very loud, so feel free to get loud with me. These are just true and false and a couple of facts. So you can get breast cancer if you do not have it in your family. Would you say true or false?
True.
Yeah. And so I think this is very interesting. While the risk is incredibly high with family, 85% of people who are diagnosed with breast cancer do not have it in their family. And so this is where you can hear that. You go, well, 85%, that sounds really high, so it's not a family tie, but then we go right back to the history. And then just remember, those that have it, though, the percentage goes really, really far up. So I think that's something that's just really interesting. When should you start doing the self-exam? So Jenn talked about that. It's almost like we planned this to go back and forth, and we really did not. I love she brought up the self-exam. So what age would you think that you start those? This is another one that is, unfortunately, a lot of myths out there. Shout it out. There's no judging. I love all of you. 20, it's 20. And so a lot of people think 40. So any reason why 40 is the magical number that people think to start self-exam?
Mammogram.
Yep.
Mammogram. And at some point, I've actually looked a few places for this. I hear 50 a lot, so I don't know if it was 50 or at some point I know there were some payers covering it at 50, But I hear a lot of times people say, oh, I thought I didn't need to do that until 50. And so that is a very common myth that is actually incorrect. So 40. When you think about a mammogram, if you do not have it in your family, you are not high risk, is it okay to wait past 40? What do you think?
No. No. Get your mammograms.
Also, another one that this one's definitely very near and dear to my heart. So I feel like I've grown up in the imaging phase, and so going back to the old school ways. And I'm going to show you a couple pictures here in a minute. It is really bizarre how the mammograms used to look and what we can see today versus then. So I really grew up in my career going from the old school film, and I'm going to show you a photo, and then moving to digital. And I dearly love radiologists, every hair on their little head. And I remember people saying, are you kidding me? Do you know how many more images this is? And we're going to really read, it's going to add so much volume. And then post going live, and radiologists and providers looking at the digital, you could not pull it out of their hands. If you said, I'm taking away your digital mammogram or digital mammography unit, they would flip out. And then I had the interesting opportunity of working with a lot of centers and working with providers that were moving to tomosynthesis 3D. And that was interesting, where providers talked about, my eyes are literally strained. And that is true. It is so many more slices and so many more images. And so we were really lucky here at KLAS that when that was released, I had worked with a few providers that were working on that pre-FDA. And I knew a couple of providers in Europe that were performing tomosynthesis before we could even get it in the States. So I was very, very fascinated. And one of the reasons I was very fascinated is due to the dense breasts. And that is something that if you go to the website, RE-Dense, very, very great website. And how do you even know your density? So you would not want to run out if you're under 40 and get a mammogram to find out your density. However, as Jenn mentioned, it's critical once you get the mammogram. Anyone that's had a mammogram can just call and ask, what is your density? And that really is just the difference. And now I wish I would have put two images side by side so you could see. But if you look on the dense mammogram, you see a lot of white. And then if you look at one where the breasts are not dense, you can see it's much easier, a lot more clarity. Yeah. And so I just became fascinated by seeing the old school and seeing how much more clear the mammograms were getting. Another myth buster will be interesting, that you can, I even my own provider, love them, but said, I don't think you want to get tomosynthesis. It's like, I'm exaggerating, about 100 times the dose. And I'm like, actually, that's not true. I've literally been there, worked side by side, the radiologist, the physicist. It is going to be more dose. Why more dose? Because you are getting a much deeper look. But the false positive callbacks, and when you have the dense breast and you get that false positive callback, to get 2 mammograms regularly, now what is happening to the dose? And so I want to be very clear. Again, providers, based on their age, their education, their background, when we talk about go check with your provider, not all providers are going to know the detail on mammography, breast cancer, and ovarian cancer. And I love that we have October. I love to think pink. But I also want to add the little disclaimer in there, which you brought up about the ovarian cancer, because I feel like we don't talk about that enough. And it is absolutely one of those ones that is in the negative bucket. So very fatal if you don't catch it. Ironically, I had a provider. I am very high risk as well. My grandmother had breast cancer, my aunt. And someone said to me, you're not really bearing children at the age. You could probably come in, and this is an OBGYN, every few years. And I almost had a heart attack on the table. Like, forget breast cancer and have a heart attack right here. And so that is like a provider that was, again, at their time, that is probably very accurate. I don't think that's a provider that's trying to cause harm or not update. But in my case, imagine going in every 3 years. That does not for OBG. And again, I'm not thinking about the baby mode. I'm thinking about the prevention and just having that baseline test. So I do think you need to make sure, yes, talk to your providers, but make sure you're digging into it and you are the captain of your own ship, so to speak. Yep. So that's something that I hope is really helpful. Also have another quick little, I guess, a trivia question. people always talk about the women, and definitely by far more women get breast cancer, but we fail to mention the men. And the really tricky part about that is the number. When, even though there is, I think this is also a bit old, I did not find a more up to date, so I think this is from 2018, that it was 2,500 men a year versus about 260,000 women a year in the US get cancer. But on the men, just under 500, and their detection is much more difficult. So by the time men find out they have breast cancer, it unfortunately is too late. So that there's statistics of the prevention and finding it early, not as great as the women finding it early in the prevention. So I love to include, does not discriminate. Everyone should be keeping their eyes and ears out. Another interesting point. I recently know someone very well that had breast cancer, did not know until later stages, was having back pain, no other symptoms. It was not originally found on a mammogram. And this person passed away of breast cancer. In the meantime, was going in for different scans on her back, having the back pain. So again, you can only imagine providers probably don't love me when I'm the patient because I question everything. I want to know why. And my friends and family, when they go in for scans, also usually don't like to tell me because I'm like, you need to ask this. Let me go. Let me be there. But it really is asking and making sure, like double, triple checking on yourself. So when we talk about age, I did find this really interesting data from 2018. Again, it's dated, it's aged, so this is likely even higher now. Real quick, do you know how many women over their lifetime will have breast cancer? 1 in 8. So if we look at the beautiful women here in pink, 1 in 8 of us. And the men was definitely different data, so I don't want to share something that I'm not confident is accurate, but 1 in 8 for women. And you hear about people talk about, well, it's an old lady's disease. I've heard that so many times. I'm not worried about it. I'm 50. I've never had a mammogram. Like, I'll think about that when I'm 60. So sobering statistics.
Yeah.
1 in 233 women are diagnosed before age 30. So we think about, that's not like 1 in 233, depends on the way you look at statistics. I look at that like, what the hell? That is, I think that's high for age 30. 40, any guesses? In just 10 simple years, 10 years. 1 in 69 in just that 10-year span. So if we move to 50, 1 in 38, and that's in their 50s, and below age 60, 1 in 27. So is this an old lady's disease?
No.
I would say not. So hopefully that's really helpful. I think another interesting statistic, cardiac, all these different things that we're all dealing with. And breast cancer in women is the second leading cause of death. So how did I get into this? Again, please don't call me an expert, but how did I become like the person that asks a lot of questions and likes to get to the bottom of it? So we'll go to the first slide. So I shared with you my my past of working in imaging and literally moving through to see some of those stages of moving towards the equipment. And I have the opportunity with Radiology Without Borders. This is actually while I worked at KLAS. So I have a really good friend also in the industry, and we had a mutual friend who I crossed over and did some work with at my previous company. I worked a lot with oncology consulting, and no surprise, the radiology oncology, just so many crossovers. And so I had the opportunity to go to Tanzania, and one of our providers that I worked with here at KLAS, we found an old mammogram unit that was not being used, that was dated for us by standards. And so Radiology Without Borders has done this quite a bit. I actually had a project in Ukraine as well and shipped that over to a teaching university. So the reason I think this is so fascinating, you look at what we're doing here and all the education. So I was so excited to go to Africa and deliver the first mammogram unit. And I had all of these pink ribbons, all of these different things that were donated. And I thought, like, here, all these people would just be so excited, throw the ribbon on and just come get a mammogram. So I thought it was really that simple. Okay, we can go ahead and fast forward. That is actually Dr. Tariq Gill, and he is the founder of Radiology Without Borders. So if you did not know what you were looking at, you would think that was actually dense breast tissue because of how wide it is. That is actually just the equipment. So he has a magnifying glass, and he's looking at that old film and literally holding that right up there and checking for anything that he can possibly see. I also love this picture. The individuals on the first part there, those are actually radiologists that had not seen a mammogram. So a full-blown radiologist at a teaching university, and he was showing them and teaching them how to read a mammogram. So very, very cool. And those are taken with my iPhone. And one of our reports, I believe it was in 2014, we actually used this cover in at the time, the designers and the people on the reporting team, they're like, where'd you get this? Like, who do we give credit to? I'm like, me, it's from my iPhone. It's sitting right there. Go ahead and forward. You can see them literally, actually, if in one of our old office, I think it moved over here, they're hugging. They were literally hugging the mammogram unit, which is really cool. And again, here it was something that was like this old thing collecting dust. And they were hugging the mammo unit. The reason I brought the second picture in, that individual, very, very fun. She had been at another hospital before and had seen some mammograms, also radiologist. And we start talking about where in the US, and you always wonder, like, how detailed do I get? It's like Utah, it's kind of like Las Vegas. I hate referencing Las Vegas, but people usually know Las Vegas, kind of by California-ish, kind of by Texas. So I instantly say Utah, and I'm getting ready to like start broadening the geography. And she's like, Utah, Intermountain Healthcare. And I was like, what? So Intermountain had previously done a mission, and she had actually met some individuals from Intermountain, Utah, which I think is really crazy, like all the way in Africa. You're into someone that has met people from Intermountain, so we can go forward. This is a chart that is actually from a KLAS report in 2014. And it shows, sorry, this is a little bit small. It shows the white states are states that are doing nothing for the notifying women if you have dense breasts. The pink were states that had the law, and the blue was pending. And you're like, why in the world is this in a KLAS chart? Because so many providers, I was very surprised. I learned more and more, and I would ask radiologists, I would ask breast imaging centers, and they didn't really know what I was talking about, which I found interesting. And also just goes to show how we had advanced, but not necessarily back to the education and back to just figuring out how do we notify people. And so this is definitely not clinical or factual, but a lot of providers that I work with, they really feel the reason. So many in the past, if you look at the survivorship, people did not survive. The numbers were not as high. Obviously, hard to go back, but was that because we did not find it earlier? You just saw Dr. Gill with the magnifying glass. And by the way, he's a breast imager and a very awesome radiologist. What do you think the odds are missing when it's so white and you have the magnifying glass with the equipment? And that equipment, by the way, is in my time, and I'm old, but not that old. So imagine when we think about going back to our grandmothers, what did that even look like? I don't even know, but it has to be different even then. So we put this in a KLAS report, and I thought it was really fun that our team started asking providers, what are you doing? What are you aware of? How are you educating? How are you notifying patients? And very unfortunately, there was not a lot of notification at that time. And so our team here started pushing. So not necessarily for the report, but no surprise, our calls are recorded and transcribed. We started getting a lot of really, really cool information, a lot of cool data that sort of just sat there in transcription, the good old fashioned manual, pull out the transcript and see. And so I think that is something I'm very proud of, to be a part of the projects and the early work we do here at KLAS. So you can fast forward. So notice the date, 2014. So clear back then, we were reaching out and saying, why is Utah not on this map? How do we get Utah? How do we notify? That's this simple as that, just notifying patients to say, you are above or you are at risk, a high density level. We just want to notify you. What does that mean? It could mean nothing. It also could mean that you should get an ultrasound. It could mean you should go and check something out further. maybe be a little more diligent on your self-exams, although I think everyone should be really diligent. But after trying for quite a long time and taking a lot of this information and the data we were collecting here, just not having a lot of luck. And I was at a conference, and out of the blue, I got a call from a lady that said, I know Eileen Gale, Kent Gale's wife, that's our founder, and she was telling me about you and the reports and some things that you're working on. And do you have any data? Do you have any information that you could help share with us? We are going up and meeting with the governor. And I was thinking, we have transcript after transcript, but how do we get to that? Like, how do you go dig that up and find that again? Because remember, it's not something we're measuring. So it was really fun to reach out. And at the time, some of our team members had moved on, and just say, who were you talking to? Literally, this is how manual. Who were you talking to? What conversations? What facility? And I'll go back and dig all this up. So we did that. And remember, we'd already shared that prior. So we just got the idea. Seems very simple. But let's not just email, let's not just send that, let's literally print all this out on pink paper and mail this in. And so at least people are opening and it's all this pink paper. And then we went back to a lot of young women. Janet Charrington was one of them. I'm not on Facebook. I wasn't then, I'm still not on Facebook. But just reaching out to survivor groups and saying, can you tell your story? How old were you? I mean, we just talked one in 233 women under 30, and then one in 69 under 40. So we said, please share your story. And do you know your density? Was this an issue? An overwhelming, yes, that was a problem. And so this is a bit of a funny picture for me. If you know me, you know I do not have a good poker face. And so finally, Utah, in 2018, we signed the bill that at minimum patients were notified. And a few of my friends, I did not share this anywhere, and they saw this in different publications. And they said, why do you look irritated if they're signing the bill? And I was like, well, let me just tell you how long this damn bill took. So I'm not proud of the length, but I'm very proud of the outcome. Not appropriate for if this was internal, and if you would like to see it, one of my friends did Photoshop a bottle of champagne flying out and also a baby. And so there are some very funny memes out there about this, and because they said my face was priceless. So I'm very happy it's done, but it is really awesome going forward. We're still not done yet. And there are many, many more things that we can do. And it's interesting too, when people talk about women, I'm like, no, not just women, men, but what about every age? Or some people think they're too young to come and learn about it. We all have mothers, aunts, grandmothers, sisters, the whole 9 yards. So thank you today for coming and sharing. I think, is that my last slide? I think so. Yeah, thank you so much. Any questions for me?
I feel like I get lots of articles saying that the mammogram, isn't very effective, and that we should be using ultrasounds, and we should be using sonograms, and what about the MRIs and all of these things. So it kind of like makes it seem like they're not very effective, so don't bother going and getting one.
Yeah, I've heard that a lot too. And this is where it's interesting that I say ask your providers, but know and understand your provider's background and their training and even their history. So mammograms are very, very effective. And then the 3D tomosynthesis, you absolutely, and this is when we went back and pulled the data that providers were saying, oh yeah, we literally are comparing a side by side. And we could see it earlier with the tomosynthesis. Now, that does not mean everybody needs a tomosynthesis. In many, the slightest lesion you can see right away, especially if you don't have the density level. Yep. So that is one thing that is really important for anyone over 40 that's had your mammogram to call and say, what is my density level? Remember, they did not have to notify you before this bill signed, and then it signed and it took some time to get in effect. And by the way, I'm the maximum. Like when you look at the density, there's not just yes or no, you have a level. And I got my letter, and my husband is an optometrist and very, I would say very strong medically. He's just done a lot of study, a lot of research, and I showed him, obviously eyes and the boobs different, but you go through an intensive amount of medical during that. And I said, what would you take of this? And he's kind of looking at it and reading it, and I'm thinking, man, if a person with this much medical knowledge, this does not alert him or shake him, what does that, because for me, and I know I am biased, I want it to literally scream out and be crystal clear and just give me a lot more information. Now, when I talk to providers about that, they also, that's my version of it. You also don't want to panic people because for the most part, remember, we are talking not everyone, and even the number is 1 in 233. So you don't want people panicking and going and getting unnecessary procedures. I also had a really good friend, and she, awesome lady, also a nurse by background, very high risk, a lot of breast cancer in her family. She got the mammogram, it came back negative. She was just for sure she had cancer. Off and on, she could feel something and then it was gone. And she just went in and requested and demanded basically an MR, did not have it, did not have breast cancer, good news. But then there was a physician that said something is tiny suspicious, did a biopsy, and it did end up causing her some harm, not cancer. And again, in her mind, going back, I was like, would you have done it again? And she's like, it was peace of mind, and there was just something itching at me. So what advice would you give someone in that? It all comes back to personal. And for me, I have other friends that say she should have never done that. Well, what if she would have had the cancer? And so it is really hard to judge. And I think that's where providers get into it's a bit tricky. Even during tomosynthesis, there were times, I have a family member, at the time it was $50, 50, to get tomosynthesis, and my own family member declined it. And this is someone that could absolutely afford $50. And I was like, I will pay, I will right now go pay for you 50. And they were just like, well, I don't see the value. My physician said I likely don't need that. That person passed away of breast cancer. $50. And so again, it's not even, what if it was 500? Let's figure it out, have a fundraiser. But it goes back to, there's also plenty of people that $50 is a big deal and they didn't need it. And I think that's what puts providers in a tricky spot. The breast ultrasound is really fascinating to me. And we also had a report, I should have added that in here too, that talked about the plans. And many providers, literally breast centers, would be like, no plans, we don't really know why we would need that. And so again, this is my bias side, my non-clinical side. And even if you found out it cost $100 or $200, for peace of mind, would you pay that every couple of years to go have that and just say, I sleep better at night, and that's like the best $200 that I ever spent. So I have heard people that go to get it, if insurance does not cover it for certain reasons, say it's about $100 to $200. Obviously, you'd want to check, and I know prices fluctuate, but it is something that you could consider. There's no dose with ultrasound. Also with MR, there's no dose. But you ask, why would everyone not get that? On the MR, it will show every tiny little thing. And that goes back to my friend that had the unnecessary biopsy that did do some damage to her breast tissue, that she did not need it. And it showed lots of little specks, and she saw that and was freaking out a bit. So that's why they wouldn't just send everyone to go get that. And all of this you can look up online. I should have included a couple of examples and photos, but I have a lot of those examples if you would like me to share. The other myth I actually had on my paper and I forgot to share. I have heard people say, oh, I'm nervous to get a biopsy. I heard it can cause the cancer to spread. I do not know where that came from, but I've heard that from a lot of people. It is definitely not true. Now, in my friend's case, where she did go get the biopsy, it was unnecessary, and it did cause her to have permanent scar tissue and some damage, and actually a permanent lump. So I don't know if there has been some of those cases that people transfer over to that it's breast cancer, but it definitely does not cause breast cancer, and it does not cause it to spread. So just another interesting thing that I've heard over the years that is not true. Great question. Yeah.
Another question, you had said not all providers are alike. How do you find one that you can trust them?
So I think let's think about a provider, and you have your general care provider, and they probably have a good baseline, but it's not their bread and butter, and they're not a geek where they're going in like myself and I'm like, let me just watch you read mammograms, or they're not really digging into the equipment part. And so I think it's good to ask them a good baseline, but look on, as an example, even just the quiz that I pulled up from the American Cancer Society. And even when you look at some of the professional and you look to those specific people, a lot of people talk about OBGYN, and I think that is probably a good source. But again, it was my OBGYN that told me every few years is probably great to come in. That always ends a meeting quickly. Any other questions? We'll see you in the parking lot.
Yep. Since it's October, before we go, this is the month. If you're over 40 or at 40 and you haven't had a mammogram, go get one. Talk to your loved ones. If you have family members that need to have a mammogram or haven't gone in for a gynecological exam, push them for that. Talk to your nieces and your daughters and younger people and ask them, and this may be a little awkward, do you do self-breast examinations in the shower? Now that you have to ask in a skillful way, but this
Or not.
yeah, or just go for it. I'd just be blunt. Tell me about this. Make sure that you use October as a great reminder every year. Reach out. Use this as a reminder for you to get done, and then we'll probably have to go because the fire alarm's going off.
One
Thank
last
you for
comment.
coming.
Yeah, there was one last comment from Catherine. She said her provider considered a 3D mammogram an upgrade, and she had to pay the difference.
Please
So
do.
please don't settle for lower quality imaging because that's what your insurance covers. Insurance does not know best, and they do not know what you need.
Yes.
Thank you. She needs to be on the panel next time.
Yes. Thank you.